Okay, where were we? We were with GLP-1 analogs. We were with dragons, Komodo dragons, and we were talking about the wonder drug that is GLP-1 analogs. So now we want to talk a little bit about DPP-4 inhibitors and SGL2 inhibitors, which are involved in the processing and turnover of endogenous GLP-1. And as I mentioned to you, it took over 20 years to make this or to discover this analog of GLP-1. So in the meantime, one of the things that researchers focused on was modulating endogenous levels of GLP-1. And to achieve this, one of the ways that they were targeting was these enzymes, that are found in the bloodstream. And as usual, I didn't have enough coffee when I first talked about this. So let me clarify a few things. That these particular enzymes that I'm showing you are different than the PC2 and PC3 type enzymes, which are responsible for maturation of the peptides. These are responsible for degradation of the peptides, but will function in a similar fashion. So these enzymes break down these secretins, such as GLP-1, in the bloodstream after secretion from the GI. And this is in part as to counterbalance, because you don't want GLP-1 sitting around. If you're healthy, you don't want it sitting around in the bloodstream and active forever. So you want to be able to turn it off. They're very similar to, you may have remembered in your immunology, you learned about an enzyme called adenosine deaminase, or you may have learned about it, or CD26, which is responsible for the degradation of adenosine. For the same, very similar idea, similar logic, is you don't want the substrate or ligand floating around and turning on the receptor forever. So these enzymes are responsible for cleavage of that first three amino acids that I mentioned to you, first two amino acids, apologies, to inhibit and no longer make the ligand function. Now, the challenge with these particular targeting these particular peptidases is they're not unique to GLP-1. They do also act on a broad range of other growth factors and GPCR substrates, which means any compounds that you make or you design, or when you treat your patient with inhibitors of this, you're going to impact other ligand receptor. Okay, so we were talking about targeting of these enzymes. So again, these enzymes are responsible for breaking down or cleaving those first two amino acids of GLP-1, but they are not specific. So they act on a variety of other peptides and ligands, so that you're going to get side effects when you treat with DPP-IV, obviously. But for the purpose of what we're discussing, they are effective at modulating endogenous active levels of GLP-1. So just shown here, you've got production of, so you eat food, you have production of GLP-1 from the gut, because the sensing, apologies, the sensing of the food in the gut is recognized. GLP-1 is produced. You then get active GLP-1 acting on all our important targets. But to turn that off, as part of the turning off signal, okay, obviously you internalize your GPCR and turn off your GPCR, but the other thing you do is you take away the ligand. And you do this by one of them, by this DPP-4 enzyme. And remember, GIP has similar effects to GLP-1, but can importantly counterbalance and has no direct effect on reduced body weight. So increasing the incretins in general will inhibit glucagon release, increase glucose-induced insulin secretion, so making what insulin you do have, or making what beta cells you do have more effective, decrease gastric emptying, and reduce hepatic glucose production. Again, lowering the effect of lowering your glucose levels, improve peripheral glucose utilization, and reducing, obviously, body weight through the satiety. What are these inhibitors? These are drugs that include both reversible and irreversible. So the reversible ones, example is vildagliptin and sitagliptin, and a covalently bound irreversible one is the saxagliptin. The nice thing is these are orally active, in part because they're relatively small molecules. They have nicely very few side effects, as long as your doses are relatively low, because obviously if you go too high, you'll start hitting other pathways. But no matter what, you only get modest elevations in the incretins. So you're only prolonging the active level of GLP-1. You're not going to dramatically increase the amounts of GLP-1 in the bloodstream. They appear to be weight neutral, and this is one of the reasons why they're less attractive than the analogs, because they don't lead to weight loss. However, they are more attractive than some of the other drugs that we've talked about that will give you edema and some of the other things that will cause weight gain. And unlike, remember those polysaccharides that we threw into the gut, these compounds do not give any GI side effects. So the lifestyle of taking a DPP and IV inhibitor is much more convenient for the patient. It's not embarrassing, so to speak. Now, as I mentioned to you, these enzymes act on many other ligands, and this comes into play specifically for some of your some of your chemokine receptors and other immune-related receptors, which would be playing a role in your cancer immunity and recognizing and monitoring cancer cells and tumorous cells. So there is a slight reported risk to slight increase in development of cancer. It's still a bit gray, but an elevated risk is significant and needs to be reported, and the doctor and the patient need to be obviously aware. And this really only just has to do with the fact that this enzyme is so pleiotropic in its actions in terms of turning off other important ligands. Okay, so we've talked about the new drug, GLP-1 analogs. We've talked about the DPP-4 inhibitors, and now let's cover the last two family of quote-unquote new drug therapies. And another important one are these SGLT2 inhibitors, which are found in the renal area. So here, it's important to remember that a large amount of glucose is actually filtered by the renal system, right? So 90% of glucose, 10% of glucose is first reabsorbed by this SGLT1 found in the renal, and 90% by this SGLT2. It's a transporter. So almost all of the glucose is reabsorbed by these two proteins, these two transporters located in the proximal tubes, and thus re-enters the circulation. So you could imagine that if you completely block both these transporters, then you will no longer reabsorb the glucose, and you allow the glucose to be excreted, okay? which would then be obviously an attractive mechanism for reducing blood levels, glucose blood levels. As I mentioned, the SGLT2, it does 90% of the reabsorption. So this is the major target for trying to inhibit it and see if we couldn't raise the level of glucose that is excreted and reduce the level of glucose, the amount of glucose that is reabsorbed, again, with the net effect of decreasing blood glucose. So what is this? What are these SGT2 and 1 proteins? These are called sodium glucose cotransporters. As I mentioned, the 1 is found in the small intestine, and it's to absorb glucose. And the proximal straight is found in the small intestine and the proximal straight tubule of the nephron. Now, obviously, it's not unique to glucose, which will obviously become an issue for our side effects. Instead, it is responsible for reabsorption of amino acids, small protein, vitamins, lactate, urea, uric acid, and obviously glucose, along with some of the small ions. Whereas the SGLT2 is found in the proximal convoluted tubes, so a little bit farther along, and 100% of glucose is basically reabsorbed along the nephron. So by blocking this transporter, as we mentioned, you essentially reduce any glucose uptakes through the kidneys. And this is just a zoom in of exactly of how the mechanism is thought to function. You've got absorption going through. You got blood on this side, urine on this side. Here, your little renal proximal tubes and your transporter. Then you've got glucose coming past, and the transporter is a cotransporter, which will bring across glucose along with small ions, obviously, to then reabsorb it across the tube and have it transported out on the other side by GLUT2 transporter. And there's a lot of interest in the regulation of trafficking of GLUT2 on the other side along with SGLT2. This process requires ATP, at least on the GLUT2 side. And as I mentioned, these SGLT2 are cotransporters. So the mechanism of action of these inhibitors is to block the transport, so you block reabsorption in the renal, and then the glucose then it just passes on through. So immediately you can recognize that due to all the other things that are responsible for this SGLT2, there are side effects related to these. In addition, it's a relatively minor effect on glucose levels. But again, it offers an alternative target which can be used in conjunction, and it does have an effect. So was approved in 2012. This drug, dapagliflozin, and it's got a preferential binding of over SGLT2 than SGLT1. Then there was more recent development of SGLT2 inhibitors in 2013 and 14. You do get relatively early on rapid weight loss, but you start to see tiredness in part because of the lack of taking up some of the other important components. You tend to get dehydration, and in some cases it can worsen urinary tract infections and thrust. So there have been some reports of diabetic ketoacidosis, again, probably likely that it's blocking uptake of some of the other aspects for this transporter, but mechanism still is a bit unclear. But you can get conjecture that this inhibitor is not specific for glucose, and that's part of the problem. But again, it provides an alternative option, and that can be used in conjunction with other medications if need be. So that's the SGLT2 inhibitors. Now let's talk about amylin and amylin mimetics. These were very, very popular at the beginning and become slightly less so lately, mainly because of the success of GLP-1 mimetics. But these still work, and they're quite a bit on the market. They're becoming a larger share. Just I think the future is less going to be amylin and more GLP-1 personally. So what are these? These are synthetic analogs of the neuroendocrine hormone amylin, which is co-secreted by the beta cells, if you remember, in response to food intake. So shown there is the sequence of human amylin, and then you can make a few substitution changes, mainly of prolines, to kind of stabilize and still get a nice mimetic. It nicely regulates glucose appearance within the bloodstream, and it slows gastric emptying and promotes satiety via the hypothalamic receptors. It suppresses postprandial glucagon secretion as well, and it has been approved by type 1 and type 2 for type 1 and type 2 treatment, which makes it particularly attractive, obviously, for type 1 diabetics, because their options for alternative pharmacological treatment is limited, right? Importantly, amylin allows reduction of insulin doses. So if a patient is already being treated with insulin, it really lowers the amount required to provide them with that and lowers the average blood glucose levels. It also reduces the rise in blood glucose that occurs in diabetics after a meal, so it becomes even more effective as the day goes on, obviously, which makes it a little bit easier to live with for the patients. It is also used as an adjuvant in type 2 diabetics, but again, it's similar to the exenatide, the GLP-1 analog. It is an injectable. So that is, again, the challenge from a drug delivery standpoint, is how to make this orally available. Now, here are some of the summaries in terms of treatment of hyperglycemia based on site of action. So we've talked, obviously, quite a bit about this. So it's a good summary slide for you to use. So importantly today, we focused on the GI tract targets. We've talked about the alpha-glucosidase inhibitors. We've talked about the mimetics of amylin. We've talked about in the pancreas beta cells the activation of our GLP-1 and DPP-IV inhibitors, where they're able to modulate and prolong, or either mimic GLP-1 or modulate endogenous GLP-1, so that we get acute improved stimulus of insulin release. We're able to prolong beta cell survival. We also have all our megalotized sulfonylureas that we've talked about, and all their mechanisms there within the pancreas and the beta cells, and their response to glucose, blocking of the potassium ATP sensitive channel. We talked about metformin and its effect on AMPK. And then all of these, or many of these, have an effect on muscle, and many of them also an effect on adipose. So this is a good summary slide for you to use in terms of study guide. So with all these tools in our toolkit, so to speak, as physicians, what are the best ways forward in terms of what is a recommended stepwise treatment for patients? Okay, so typically, you're talking about, first you want to obviously make sure and measure glucose levels. You want to measure HbA1c levels. You want to check for what's the BMI of your patient. And you want to look at side effects. And obviously you want to look at costs. So for all of these, the initial therapy typically in almost every country is metformin because it's cheap. It's very, very cheap, low side effects, and it's relatively effective. After that, if after a few months you see that the patient is not responding very well to metformin, then you can start to consider drug combinations. So the next thing would be to consider, depending on how high the HbA1c levels are, what is the risk of hyperglycemia, how obese is your patient, do you need weight loss, and what side effects can the patient live with. For example, if they've got a cardiac condition already, do they have a renal condition, and then obviously what is the cost. So in the UK, it's a public healthcare system, and costs are very, very are considered tremendously. In the US, where they have no public health care or very little, they are much more likely to go for more expensive treatments and force the patient to pay a bit more. So it really depends on the healthcare system available, and I believe in China you have a hybrid healthcare system, but I'm not completely familiar with the costs in China of healthcare. I know I've been exposed to both the private and the public, but it's a bit unclear the cost structure. So I don't know what the priorities are there. Obviously, as a physician, you're interested in providing care for your patient. That's the most important, obviously. Then if the patient doesn't respond to the second line treatment, then you can consider third line treatments. And here you have to pay attention to what combinations are available and what is going to be compatible. And typically the third 3-drug combination involves insulin, okay, typically. This last one over here for second line, you don't usually do metformin and insulin right away. Usually you would try one of these other inhibitors or these other compounds that are targeting something else to try and really give you that extra tweak before going to insulin injections, because insulin is, for all the reasons we talked about, is difficult to monitor, right? You have insulin that changes all day. You have, do you use a pump? Then the pump can risk infection, and it's just a bear to deal with. So typically, insulin, multiple or daily doses of insulin are typically the last option for treating patients these days. In the old days, it was obviously the only option, but these days we have a lot of other drugs and compounds available to us that really, it's really transformed the lifestyle for patients with especially type 2 diabetes, for their ability to move on and live much longer. And obviously, from a healthcare perspective, it cuts down also on all the nasty side effects that really advanced type 2 diabetes can cause. And so these drugs are really lifesavers in many respects, and they're a real credit to the global scientists around the world that have contributed to this, from China to Australia to the US to Europe. The people that have made these breakthroughs and discoveries, and whether it be the inhibitors, whether it be the compounds themselves, whether it be the analogs, and it's just a really tremendous breakthrough. If you look at all the science behind every one of these drugs to get them and to help people out is really, I think, inspiration. So now, if we're not done yet, as I mentioned to you, there's still a lot of interest in particularly these GLP-1 compounds and mimetics. There's a lot of interest in trying to find better ones and then taking that forward for treating obesity and trying to reduce the onset of type 2 diabetes early on, and obviously at the same time combat our growing epidemic of obesity. Importantly, there's also a tremendous amount of interest in beta cell therapy, stem cell therapy. So how can we, especially for this is particularly relevant for type 1 diabetics, where how can we replenish or renew their beta cell secretion in a way that is producing enough insulin for them to function. So there's a tremendous amount of research involved in this and to try and take this forward. Despite all the breakthroughs and discoveries we've made over the last 80 to 100 years, there's still a lot of interest in trying to do that. And as I mentioned to you, one of the companies that I was learning about and speaking with was in Suzhou, and I'm sure there are many others in China besides that one. Okay, so this is just a summary slide of some of the things we've talked about that I would expect you to be able to be familiar with and be able to answer if there are any questions on an exam. And thank you very much. And I really I'm sorry I couldn't see you in person this year, and I wish you all luck in your careers and in whatever next steps you're taking. And obviously, if you're ever in London, let me know, or if you're interested in doing research in London, let me know. And we work in G-protein coupled receptors, as I've told you, or with Carlos. Carlos has a wonderful program looking at pituitary tumors of children. And there are many other wonderful endocrinologists in the department. We also have very good cardiovascular research, very good neuroscience, and obviously basic research, obviously as well. So, with that, I will leave you.